Very good morning, all of you. At the outset, I would like to thank Dr. Rashmin for inviting me to give this talk on OCT in neurophthalmology. So, OCT basically captures the tip of the afferent pathway, that is the optic nerve head, and gives us reproducible and quantifiable measurements in terms of the peripapillary retinal nerve fiber layer and the ganglion cell layer. Of late, the enhanced depth imaging gives us the cross-sectional image of the optic nerve head, and it reaches right up to the lamina cribrosa. And it competes with the histological evaluation to study the pathology of optic nerve diseases. With the advent of newer technology, a lot of machines have been added, and with every advancement, a new feature is added. I'm not going into the details of the machines, but I would like to discuss the protocols which are used to capture the peripapillary retinal nerve fiber layer thickness and the ganglion cell layer thickness. So for the RNFL, peripapillary retinal nerve fiber layer thickness, we need a circular cross-sectional retinal scan of around 3.4 to 3.5 millimeter diameter centered around the optic nerve head. Now, the two commonly used SD-OCT machines are the Spectralis and Cirrus. My talk will be mostly around these two protocols. In Spectralis, we get the average RNFL thickness in 4 quadrants like this. And in Cirrus, again, 4 quadrant averages are given. Along with that, 12 clock hour averages are given. In Cirrus machine, these calculations are done based on 6 millimeter into 6 millimeter data cube, which captures, which is done by using the optic disc cube 200 into 200 scan, and this is the output. Coming to the ganglion cell layer in inner plexiform layer thickness analysis, this can be done by a machine which has this feature, that is retinal layer segmentation. So in Spectralis, what we can get is, we can get the ganglion cell and inner plexiform layer thickness separately, whereas in case of Cirrus, it's given as a combined value. And in case of Cirrus, this calculation is done around, it's an ellipse that captures the averages here. In case of Spectralis, it's a circle around 2 millimeter in radius. Now, how do we read these? Now I'm going to show you the Cirrus RNFL map. Here the first thing is that RNFL thickness map is showing the yellow and orange areas are showing where it is thick, and the blue area is showing where it is thin, the retinal nerve fiber layer. And on the right side you can see is the RNFL deviation. That means this thickness, how different is it from the normative data. Then the actual parameters of the optic nerve in terms of the disc area, rim area are also given. You also have the cross-sectional images. You will see all these things, and this is a RNFL circular tomogram. So this is the cut section of retina along this circle here, you can see. Next, we also have the NRR thickness from both the eyes and RNFL thickness from both the eyes. And lastly, we get the averages along the clock hours and the 4 quadrants. This is about your RNFL map. Let's look at the GCC map. Again, the same color coding. We are seeing this ellipse. It is showing, the yellow is showing the maximum thickness of the GCC, and the blue is showing the thin area. Adjacent to that is the normative. Compare it with the normative. This is looking pretty normal. The more red and yellow is here, that means it is more abnormal. And then we have the averages along the 6 sectors of the ganglion cell. Now, how is it important? These two things, the play of these two things, we'll see in the clinical use of OCT in neurophthalmology, our today's topic. So, in optic neuritis, what we see is there is thinning of the RNFL, peripapillary RNFL. What is important is that it is not attack-based. That is, even if the patient has not had optic neuritis, has multiple sclerosis, then just like patients with Alzheimer's and Parkinson's, they show a progressive thinning of the RNFL. The same thing happens in multiple sclerosis. Whereas if a patient has NMO spectrum disorder, the patient gets an attack of optic neuritis and there is a thinning. So that's the main thing. In acute case, obviously there is exoplasmic flow stasis, then you will have thickening. And this thickening gradually over 4 weeks sets into thinning, and one peculiarity in NMO spectrum disorder is that the superior and inferior quadrants are more often involved, and in case of MS optic neuritis, the temporal quadrant thinning is more often seen. But retinal nerve fiber layer thinning is not, you can't correlate it with the visual acuity or the fields of the patient. Whereas the ganglion cell thinning, ganglion cell layer thinning correlates very well with the vision and also with the visual fields of the patient. In NMO, again, this layer is severely thinned out. You see a lot of red there in NMO spectrum disorder, optic neuritis. Takes around 2 weeks. We saw that thickening of the RNFL is immediate. This takes 2 weeks. Now let's look at some examples. This is MS optic neuritis, acute attack in the right eye. And here you can see acute attack. There is some thickening of the RNFL here. And what we see is in the left eye also, there is some thinning occurring there. So it's showing that in the left eye also something has happened. So OCT can detect subclinical disease activity, and it is showing me that there is dissemination of disease in time and space. The other eye is involved time because it's like you've captured between that in the past you have captured the attack has occurred. Similarly, if the OCT is showing same values over a period of time, then and the patient is on treatment for MS, then it can be taken as evidence of disease, no disease activity, NIDA. Okay. Now in NMO spectrum disorder, here the disease is very aggressive. Patient had such a poor vision, right eye, it could not be done. Left eye, you can see that superior and inferior, there is thinning. As I said before, it is more often seen. Now, what do we glean from the GCC layer? The same two patients, multiple sclerosis, right eye. I said nothing will happen within 2 weeks, so there is nothing happening in the GCC averages in the right eye. But in the left eye, where there was only one quadrant involved in the RNFL, here you can see lot of thinning occurring in the GCC. And in NMO spectrum, it's all around red. Severe thinning is seen. Another feature is microcystic macular changes. When the optic neuritis is very severe, that is 20% of cases with NMO spectrum disorder and 1 to 5% cases of MS optic neuritis, you see small hyporeflective spaces in the inner nuclear layer, and it occurs because of the loss of the retinal Muller cell function. Now, can we use RNFL thickness to diagnose a patient with cellular mass? Let's see. Now, this patient has a cellular mass, and I'm seeing that in the right eye, the RNFL thickness is normal. In the left eye, there is a few clock hours of thinning. But look at the visual fields. It's giving me much more information. I'd rather use visual fields to diagnose, okay? That's what the papers say. But now let's see what the GCC layer tells. The same patient. Now look at the GCC. GCC is telling me more than fields if you see here. It's completely washed off here in the left eye, and here fields is still showing some area, white area. And the hemianopic defect is perfectly matching with the hemianopic defect in the visual field. So a hemianopia on perimetry can present as hemimacular atrophy on the GCC thickness map. This is important, and it occurs before the visual field changes. Okay, I showed you here it's occurring before the visual field changes. Another thing that it can be used is for monitoring the patients. So you've done the surgery and you want to monitor. If this patient, I've done OCT in 2016 and in 2019, it's remaining the same. I know there's no chiasmal compression, at least that much I can tell. Another thing it can be used for is in predicting the visual outcome. If there is severe RNFL thinning, severe GCC thinning, then you can tell the patient that not going to recover much after the surgery. In ischemic optic neuropathy, you can diagnose a cupless disc in objective way. You can pick up the subfoveal fluid and you can tell, while you'll regain vision when this fluid gets absorbed. In acute cases of NAION, you have a disc swelling, and then over a period of 2 months, 80% of patients subsequently show RNFL thinning. Now coming to OCT in pseudopapilledema, this is like in continuous evaluation. Now in pseudopapilledema, around 60% of patients will have these peripapillary hyperreflective ovoid mass-like structures which are called forms, and these are actually herniating optic nerve fibers. And you can see in acute, this is true papilledema here, And this is forms. Inferiorly, you can see this is pseudopapilledema. But these forms can be present in other conditions also. Now, in pseudopapilledema, certain pseudopapilledemas are associated with drusen. Not every pseudopapilledema is drusen, but there are certain pseudopapilledema with drusen, which the Optic Disc Drusen Studies Consortium has defined as hyporeflective core with crenated hyperreflective margins.
Shikha, one more minute.
Yeah. So I'll stop when you ask me to. So SD OCT should be done in EDI mode, 97 sections, and autofluorescence should also be used. These are some more images from there. In true papilledema, you can pre and post treatment monitor, but GCC should be maintained if you want to prove that the treatment. If you're losing GCC, that means there is the treatment is not working. The last two slides, very important to differentiate optic neuropathy from maculopathy. This is where it really is in use clinically in Azure and HCQ toxicity. And new thing that is swept source OCT can be used to diagnose the congenital disc anomaly. Here you can see the disc pit with the disc pit maculopathy. And this is my last slide. OCT, I'm not going into it, but one important thing is that this layer PRC and peripapillary radial capillary network is not visible on FFA, but is visible on OCT. Thank you.
Thank you, Shikha. Any comments from the chairpersons, and then I'll invite panel maybe for.
I think Dr. Shikha has very nicely given an overview of how the OCT has enhanced the corroboration of the findings which were otherwise known, giving the diagnostic aspect, especially in conditions like papilledema, distinguishing from pseudopapilledema, which has become a very good asset in our armamentarium. And we have also seen, in addition, that the angle which is made by the pigment epithelial layer, which is different in glaucoma. In glaucoma, it is moved towards the backwards, whereas in the papilledemas we have found, compared to the pseudopapilledema, the angle made is in line. So this, I think, is there in the IG also published. So this is another additional thing. If you take a cube of the optic nerve head, just like the macular cube, if you can use the same program for the optic nerve head, you can have the angulation of the pigment epithelial layer, which will tell us a differentiation from a papilledema from pseudopapilledema. And the drusen, of course, she has nicely highlighted the role of foams.
Any comment or question from the panel?
Just have one point to make. Apart from diagnosing or monitoring nerve fiber layer in tumors being operated, can we monitor the course of papilledema? Apart from diagnosing it, can we also monitor the course of papilledema who are on treatment? So,
Provided we have the GCC layer thickness maintained, you can monitor RNFL thickness going down after treatment is a good sign, but you also have to look at the GCC. If GCC is also going down, that means RNFL thickness is going down because of atrophy, not because of treatment. So that's the only catch.
Yeah, and the angle also tells us, by the way. If you measure the angle, that will also show us in prognosticating, because after the papilledema is controlled, this angle gets normalized. So that's another tool.
Dr. Sikha, that GCL and IPL is much more for this toxic optic neuropathy. They can give so much evidence. Now, do you find Alzheimer or Parkinson effect in GCL and IPL if you have screened those patients? Because that is where
It's been
Documented.
used as a biomarker.
Marker.
OCT is being used as a non-invasive biomarker. It's coming there, and it's more than GCC. I think RNFL they are looking. I did speak about Parkinson's and Alzheimer's, where RNFL thinning is dominant.
thank you.
All right. Virinder?
Thank you, Dr. Rashmin, and thank you, AIOS, for giving me the opportunity. I'll slightly modify the topic to optic neuritis in 2022 current understanding, because most of the new things have become standard practice most of the places. So I'll be trying to cover into the following headings: what are the current insights into the etiology, what is the current recommended workup, guidelines for treatment, a little bit about pediatric optic neuritis and COVID-19 and optic neuritis. Well, we all know that optic neuritis is primarily secondary to demyelination, and it could be either as an isolated disease or a clinically isolated syndrome, but more often than not there is some associated CNS disease, The most common four etiologies being multiple sclerosis, acute disseminated encephalomyelitis, neuromyelitis optica, and MOG-associated demyelinating disorder. In India, we should never forget the para-infectious and post-vaccination demyelinations that are quite common. So, what is the current literature that tells us about the etiology? So, this is a Western study coming from the Rochester group, where they looked in the population-based incidence of patients seen in a single center between 2010 to 2018, and they found that the annual incidence was about 4 per 100,000. Majority of the patients had multiple sclerosis as the final etiology, but about one-third was idiopathic, and fortunately NMO and MOG accounted for only 9% of all cases, but it is still not less, 1 out of 10 cases, because they can be associated with recurrences and suboptimal visual outcomes. Similar literature coming in pediatric age group from the PD group showed that final 6-month diagnosis was one of the neuroinflammatory syndromes in nearly 1 out of 2 patients, 50% of patients. And most common was MOG, followed by EDEM, and then multiple sclerosis. If you see here, NMO is slightly more than the reported incidence in the adults. What about Indian data? So there is a very good study that has come up this year from SN group, and they screened 203 patients of optic neuritis between 2018 and 2019. They were worked up with neuroimaging and serological testing, and what was found was that MOG was the most common disease, final etiology, followed by multiple sclerosis in 1 out of 10, and NMO was about 5%. What was very important message was that despite extensive workup, nearly one half were double seronegative for NMO, MOG, and did not have MS also. The study also showed that there was female preponderance in MS and NMO, but not in MOG. So, but why it is important for us to distinguish between the final underlying etiology? It is so because the chances of recurrence are different in each disease, as well as the amount of damage that can happen and the progressive neurological disability that can happen is different with MS and NMO. So, do we have some clinical clues? So, this is a study from a UK group by Hekohen and colleagues, where they looked at the differences between different diseases in recurrent cases, and the message that was coming was that patients with MS versus non-MS more often tended to be female. They were adolescent and young adults and never presented with EDEM-like picture. They were more often to present with a brainstem clinically isolated syndrome than any other type of the demyelinating disease. We know with MOG optic neuritis, there are certain features which go clinically to tell us that this could be MOG associated optic neuritis. For example, hemorrhages around the optic disc, which are otherwise atypical feature for MS, associated CNS dysfunction, presentation with seizures, confusion, confabulations, area postrema syndrome, prolonged hiccups, vomitings, and they do tend to have recurrences with good outcomes. And even on MRI, we can see larger lesions in patients with MOG optic neuritis, like EDEM-like picture. The study also showed some differences between NMO versus MOG, and the patients with MOG-associated optic neuritis were younger, around 6 years of age in children, and presented with monophasic disseminated encephalomyelitis, whereas patients with NMOST presented more often with transverse myelitis and more often with area postrema syndrome as compared to patients with MOG-associated optic neuritis. So given this, what should be our recommended workup in today's age? Well, we need to do the ocular investigations to document visual functions, visual fields, which are very important. We need to document structural damage, OCT, RNFL, and MGCL, which was very well elaborated. But you may skip it at the presentation. You can do it around 3 to 4 weeks when the changes will start manifesting. And if you have diagnostic dilemmas, then we can go to VEP and OCT angiography. But what is very important, what is a systemic workup? You need to get a neuroimaging, ideally serology and CSF analysis for all. But do we have some clues? Do we skip this a bit? So we'll come to it through this slide. The most important investigation I think all of us obtain is a MRI. The most important thing over here is to understand how the MRI can give us clues to the underlying etiology. So if we see this adapted figure from this landmark article by Dutra and et al., we can see that in MS, the optic neuritis tends to be involving one eye at a time usually. It tends to be smaller lesion involving less than 1/3 of the optic nerve. The MRI of the spine can show presence of anterolateral columns, white matter lesions. They tend to be smaller lesions. They are not contiguous big lesions. And what is characteristic is the presence of multiple brain lesions. You can see periventricular lesions, you can see subcortical, juxtacortical, and even in the brainstem. As compared to this, NMO-associated optic neuritis will usually have bilateral optic neuritis, can be long segments, can involve the chiasm and the prechiasmatic optic nerve. The spinal cord lesions, they are big, involving more than 3 segments, 3 contiguous segments of the spinal cord, located mainly in the in the dorsal spine and the lumbar spine, and the brain lesions are usually in the periappendymal areas. In MOG, there can be bilateral optic neuritis, but involvement of chiasm and prechiasmatic optic nerve is rare. Lesions can be long in optic nerve. Similar to NMO, we can have LETM lesions or long transverse myelitis lesions, but involve the sacrococcygeal area more often. And we can have big Adam-like lesions in the brain, but they can be involving the area postrema as well. So if you keep this picture in mind, you have some clue, and then you can definitely get the serological workup based on this. This is similar observations made in the landmark article from SN this year, and what I was showing before, the NMO can have periappendymal lesions. These can be very important when your serological workup for NMO and MOG is negative, but these lesions can give us the clues to the diagnosis. So to say MRI is a must, it will rule out other structural lesions, but we should image MRI brain and orbits with contrast. And MRI spine can be very useful. Ideally, many centers recommend doing it early, but definitely if you have recurrent disease or you have very strong suspicion for MS. I'll skip OCT because it's very well covered, but I would just like to say that the loss will be evident after a few weeks, and you can do it at that time. And there, the amount of loss that happens with NMO and MS is much, NMO and MOG is much more as compared to MS. A very small word about OCT angio. We can see that both patients can have extremes of presentation, like a 40-year-old person presenting can be NION, can be MOG-associated optic neuritis, and they can have hemorrhages in both. So given that, OCT angio can be given some clues. We can see the capillary perfusion dropouts in NION, so it can help in diagnosis. So coming to briefly to treatment, most principles of ONTT apply, but the acute phase management is towards 5 days of IVMP, followed by second line treatment with plasmapheresis if you are not getting good response. And chronic phase, we need to give specific immunomodulators. It is very important to give for MS and NMO because the chances of progressive neurological disability is much higher. But in MOG, fortunately, the 70% of patients do not have recurrence, do not have progressive disability, so you can do it only for the recurrent cases in MOG. There are many treatment options. Plasmapheresis and IVIG are becoming standard of care for poor recovery optic neuritis and NMO. And other monoclonal antibodies, it's beyond the scope of time to go into that, but they are becoming mainstay in NMOST management. Very last slide telling about COVID. There is significant amount of reported literature which tells that COVID can have a prodromal association, can have a temporal association presenting with demyelination, and if you see the literature, it can be either any of these. Patient can have recurrence in previously known case or de novo. So we need to do a workup to rule out COVID-associated optic neuritis and take a relevant history. So with this, I'll conclude. Thank you very much.
Maybe one comment from the chair and one from the expert.
Maybe Dr. Ambika would like to say.
Very nice talk, Dr. Virender. And probably I think you have to add for the atypical optic neuritis blood workup also in all these cases, because it should not be a overdiagnosis of a demyelinating spectrum disorder. And we do deal with non-demyelinating group of disorders also in this bracket. And if you're going to deal with a patient who is in the 40s and earlier, before the onset of MOG spectrum disorders, there would have been overdiagnosis of an ischemic optic neuropathy without any treatment options. So watch for them also.
Yeah, definitely the point.
And I would like to know what's your experience in recurrent and poor visual optic neuritis, and what is the first line of drug you choose? You plex them?
Yeah, we are tending to, when it's poor recovery optic neuritis, whether NMO or double double seronegative, we are going towards plasmapheresis followed by IVIG.
Okay, because sometimes when we have these seronegative spectrum disorders, better if the neurologist is giving a choice of interferons, just be careful because this is going to worsen the spectrum of a NMO versus than a MOG, if at all it turns out to be a MOG in the future. And watch for what testing tool they are using for these seromarkers, because the sensitivity and specificity can also be down.
Very well taken point. Thank you.
May I have Dr. Swati? Any other point from any other expert? Yes, ma'am.
Is there any role of plasmapheresis in double seronegative patients of optic neuritis?
Yes.
Because plasmapheresis is supposed to remove the antibodies. But when the patient is double seronegative,
I think Dr. Ambika just alluded to that the sensitivity of the test is very low. So it could be false negative. So we don't know. If you are able to remove the load of antibodies, the patient's prognosis visual outcome might be better.
Maybe I would prefer a rituximab in that version. If the rituximab doesn't respond, probably Plex will be the later option unless the patient is having a neurological manifestations.
Virender, in COVID-19, do you see both MOG as well as aquaporin positive in some of the situation?
We have seen 12 patients where we could allude to COVID-19 and only NMO was positive in only one. Rest all were seronegative for everything.
Okay, thank you.
Rest workup was negative.
because in our plasmapheresis is done by other department, not by. So when you refer, then they say when there are no antibody, what you are going to gain it. So that's why I'm asking.
So I think the other thought is maybe there are antibodies which we are not able to detect right now. I mean, every day now they are detecting new antibodies. Yeah, can we have Dr. Swati?
Your mask. By Dr. Sachdeva on optic neuritis.
Take off your mask.
Much has changed in optic neuritis, but not much has changed as when the traumatic optic neuropathy is concerned. So just an overview of what we already know about traumatic optic neuropathy and where we can actually make a difference. So to begin with, traumatic optic neuropathy is a vision-threatening condition and is caused by ocular or head trauma. Facial trauma and closed head trauma are the most common causes for it, and in around 0.7 to 2% or up to 5%, it can be associated in all causes of trauma. There can be a direct nerve injury or an indirect nerve injury. So direct nerve injury is one where there is an direct anatomical disruption of the optic nerve, which is associated with injuries to head, face or orbit. And this forces, when there is a blunt injury to head or directly on the brow, these forces are transmitted to optic canal, causing the fracture of the optic canal, which can compress on the optic nerve and cause traumatic optic neuropathy. This can also be because of the projectiles. If it's a penetrating trauma, so certain foreign bodies or certain projectile can get lodged in that area and can damage the optic nerve. The indirect injuries is little different. It is again by the forces that are applied to the bony orbit or to the head or to the area around the brow, and because of the tight adherence of optic nerve at the optic canal, there is a kind of acceleration, deceleration forces and leading to concussion injury, leading to mechanical shearing of retinal ganglion cells that causes an irreversible neuronal loss and loss of vision. Here the most common site of injury is intracanalicular part. Why? Because it's the most fixed part, the immobile part of the optic nerve. Sometimes you may see the hemorrhage within the optic nerve sheath, or there may be hemorrhage in the orbital cavity. And this hemorrhage compromises the circulation of optic nerve and may result in compartment syndrome. So this is where probably a surgical intervention may make difference. Coming to clinical features, the patient will present with the classical history of blunt trauma, which may be actually on the brow or somewhere in the on the face or maybe forehead. The presenting visual acuity is generally very, very poor in around 60% of cases. Many of them may present as low as no PL as well. If the vision is good at all, you may have loss of color vision and contrast vision. That will depend on the severity of injury. Sometimes you may see that there is a contralateral eye involvement also, so you may have a poor color vision and poor contrast sensitivity in the other eye also. Presence of RAPD will be there as with any other type of optic neuropathy. Proptosis and disc edema may suggest orbital hemorrhage, so one should look for it actively. So if the injury is anterior enough, it may actually cause optic nerve avulsion, which may be seen as a ring of hemorrhage leading to retinal infarction and central retinal artery occlusion. More posterior injuries, the fundus may actually be normal, and this pallor develops around 6 weeks of the injury. Coming to investigation, so like in any other setting of acute trauma, CT scan here is the treatment of choice vis-a-vis in other optic neuropathy cases where you want to do MRIs. So it's important to do CT scan with fine cuts and axial sections of around 1 to 1.5 mm to rule out optic canal fractures, to rule out optic nerve sheath hemorrhages. MRI of orbit, if at all done, may reveal a focal edema of optic nerve or optic nerve sheath enhancement with gladinium. So if at all one has to prognosticate the case, maybe VP and electrophysiology in form of ERG will help. So if the studies have shown that if the amplitude is less than 50% in a unilateral cases, if you compare the two eyes, if the amplitude is less than 50%, it is suggestive of poor prognostic signs. Similarly, for electroretinogram, if the waveform is flat or of low amplitude, suggests again the poor prognosis. Coming to management, it's still controversial. The role of steroids, role of surgical decompression, everything is controversial. We don't have a definite treatment for traumatic optic neuropathy till now. It has been reported that around 25 to 50% of cases may improve on their own and could be of maybe indirect traumatic optic neuropathy. And baseline visual acuity is the most important factor that can predict the final visual outcome. The cases which are associated with multiple orbital fractures or facial fractures generally have poor prognosis. So these are two studies which have been done and have shown the role of steroids. As I said, the National Acute Spinal Cord Injury study has shown us that probably steroids, if given in very, very high doses, as high as mega dose of 30 milligram per kg as a loading dose, followed by around 6 milligram per kg for next 24 years in a very early period, in a short window of say around 6 hours or so, may help in salvaging the vision, may help in salvaging the optic nerve. But contrary to this study, the other study, which is a corticosteroid randomization of significant head injury crash study, has shown us that mega dose, if given within 48 hours, can actually cause the worsening of the mental status. It may increase the cortical edema and may actually result in death. So this study was stopped in between. So comparing all the treatment options, whatever we had, the International Optic Nerve Trauma Study was done, and they have seen the results with observation with high steroids and also with optic canal decompression, but they concluded that nothing, neither the timing nor the type of treatment can affect the outcome. So there are very few, small subset of patients where actually surgical intervention may help, and one of the one of the most serious complication which can occur is orbital hemorrhage, and where your intervention, a small canthotomy or cantholysis, may actually help in decompressing the orbit. You may drain it also, and probably may prevent the irreversible loss of vision. Patients, if have any kind of impacted bony fragment impinging on optic nerve, doing a decompression may help. Intra-sheath blood, if it's convincingly, if you are definite that it's there, the optic nerve sheath fenestration may be indicated in such case. Thank you.
Any of the panelists would like to comment?
I think VER response has a recording is also very predictive in these cases. As Dr. Mahapatra published a very large series of patients, and he came out with the conclusion that if you have a positive response, these patients have a more chance of recovering the vision. Than the response is negative, then the they are a very poor prognosis. So I think we are also a role in
Yes, ma'am.
predicting the visual
Yes,
outcome
yes.
in these cases.
Yes, ma'am. That's what I said. That if the amplitude is 50% of what is there in the other eye, maybe it suggests a good prognosis
And
vis-a-vis the flat wave.
also because of medico-legal aspect which will always
Yes.
be associated with trauma.
Yes, that's true.
So one
Can
more
I
thing that
just-
Dr. Mahapatra suggested was that if you find edema on the imaging, then there is a role of steroids. So even if the patient is coming, let's say around a week, and you still see edema, in those cases, oral steroids he had given for 2 weeks, and that those cases showed some improvement. So maybe just a decongestion.
Can I just ask with regard to the medical legal, is there any particular practice pattern that you follow when to treat with steroids, when not, or do you individualize it to the case in front of you?
Yeah, most of the time we do individualize because there's no definite criteria when you want to treat or you don't want to treat. So as sir said and ma'am said that if you have some kind of response on VP and the patient does not have any neurological contraindication, which is much more important because it may worsen. So in those cases maybe steroids can help.
So
But
apart
not in
from
all cases.
contraindication, the try.
Yeah.
Oral only. I mean,
Yeah,
not
yeah,
high
not
dose.
IV, yeah,
No
not
mega
IV.
dose. No mega dose for
No
sure.
megadose, yes.
One point I would like to add. So we before giving steroids, all of us have to. You have mentioned about the crash study, and so whenever there is a simple rough guideline is to ask for any CS of rhinorrhea. So
Oh,
whenever
yeah.
they have a CS of rhinorrhea, it's better to avoid steroids because we have an open communication.
Indeed, yes,
So
point well
to
taken.
totally better
Yeah,
to avoid
indeed.
steroids. And another thing, whenever there is a deterioration of vision, the patient is getting better, but it again deteriorates, it might warrant a repeat neuroimaging and perhaps an sheath decompression or a canal decompression.
Right.
So occasionally that situation.
Or even a CT scan to see if the bone fragment is impinging on the optic nerve. That can give rise to progressive loss of vision. Except,
Yeah.
yeah. Padmavati.
Thank you.
So next we have Dr. Padmavati joining us from Arvind Eye Hospital. She's going to talk about 6-nerve palsy.
A very good morning. At the outset, I'd like to thank the AOC and Dr. Rashmin for giving me this opportunity. The topic assigned to me is sixth nerve palsy, my approach. Okay, as everyone knows, sixth nerve, known as the abducens nerve, has its origin of nucleus from the pons. It innervates the lateral rectus muscle. So the action is when you have a sixth nerve palsy, you have a restriction of abduction. Most of the patients, they present with a complaint of double vision or misalignment of the eyes. So what happens when you have such patients? You have face turned to the affected side, or you could have a floating saccades and esotropia maximum on the side of the palsy. Coming to the epidemiology, the annual incidence of abducens palsy, it is around 11.3 per 1 lakh patients. This was based on the study of Patel et al. If you see, the commonest ischemic nerve palsy is sixth nerve palsy, of which sixth nerve palsy is the most common. This was a study done by AIMS, and this was our study where we had also seen as the sixth nerve being the commonest affected nerve. So we have different age groups of different cases of sixth nerve palsy. We'll see one by one. So this was my 6-year-old who had presented with esotropia of acute onset deviation, acute onset. She had a visual acuity of 612 in the left eye. Actually, she was thought as a case of amblyopia. She was advised patching, but after the patching also they found the esotropia had no improvement. So they thought whether is it something else. So she was referred to the Neurophthalmology department. So going on to the history suggested the parents were sure that the child didn't have squint since childhood. And moreover, we had asked for review of the old photographs which showed she didn't have any squinting at that present. So we went ahead with the imaging, and this was suggestive of a left-sided cavernous hemangioma. So this was a child where you have, when you have an acute onset ET in a child, it is mandatory you do a neuroimaging. This was a 31-year-old male who had presented with a right sixth nerve palsy. He was seen by a neurologist, imaging done, everything fine. He came for a second opinion to the ophthalmologist. So what is next? If everything, we had done a neurological assessment, but the clue was in the fundus, which shows a disc edema, where the sixth nerve is suggestive, is secondary to as a false localizing sign. So this was a case of, diagnosed case of idiopathic intracranial hypertension. Moving on to my case 3. This is a 50-year-old female. She's a known diabetic with a sixth nerve palsy of left side. So will you think this is a ischemic, or will you go ahead with the neuroimaging? If you see, her HbA1c was high, relatively high. And moreover, the imaging was absolutely normal. So this was presumed to be a microvascular ischemic cause. The next is a 65-year-old female. She had a left sixth nerve palsy. So will you take this case as a ischemic sixth nerve palsy? The clue is in the other cranial nerve examination, where you have the 5th, 7th, as well as the 8th nerve involvement. So you know the lesion is at the CP angle, but the surprise was she had multiple metastatic lesions, which was suggestive of, and the primary was in the breast. So a simple sixth nerve palsy diagnosed a case of CA breast. So this is another patient who was a 70-year-old. He had a sixth nerve palsy. So we didn't advise for an imaging, but we went ahead with the blood investigations to rule out a raised ESR or a CRP, to rule out a GCA. If it is non-resolving, maybe we'll go in for an imaging. The last patient is a young patient who was referred as a sixth nerve, and one of my postgraduates had advised for imaging. But if you see the extraocular movement, this is a case of DRS. I think you can make out the widening on abduction and narrowing on adduction. So whenever you have a sixth nerve palsy, the age of the patient, the nature of onset, progression, vascular factors, and the next important point is you have to know whether the palsy is isolated or non-isolated. It is mandatory you have to examine the 2nd to 12th cranial nerves. Not but the least, pupil also holds an important significance in sixth nerve examination, because your Horner syndrome can be associated with lesions of sixth nerve. And these are the examination tools which you would normally do for any case of diplopia. Mark my point, every patient has to be assessed for her abnormal head posture, lid position, as well as the eyeball position. If you say always, the debate of neuroimaging is always there, where most of the neurologists would go ahead with the imaging, but ophthalmologists would have a rationale whether we would do a imaging at the first visit or at the second visit. So this study was done in the SN, where they had found that the diagnostic yield was around 48.64%. And this was a multicentric prospective study which assessed whether neuroimaging is needed early in acute isolated cranial nerve palsy. They found that the 16.5% of the cases, they had other causes which caused a nerve palsy other than the ischemia. So they said that brain MRI with workup is needed initially in all cases if vascular risk factors are present or not. So whenever you examine for the sixth nerve palsy, look for proptosis, lid retraction, lid lag, ultrasound, and thyroid function test if you suspect a thyroid eye disease. If you have a pain, it is more suggestive of either an ischemia or a inflammation. If you have a history of trauma, do a positive force ejection test to rule out a entrapment of the medial rectus. Not but the least, always look for mild ptosis and lid twitch. Also do the fatigue test as well as your neostigmine test to rule out myasthenia gravis. If it is non-resolving and no cause found, again re-evaluate for myasthenia gravis. When you have a recurrent nerve palsy, what are all the differentials you should think? One is your uncontrolled diabetes, multiple sclerosis, migraine, myasthenia gravis, connective tissue disorders, and recurrence of tumors. So the management includes occlusion, Fresnel prisms. This is for temporary. Usually you have resolution. Surgical interventions include Botox as surgical correction. This was one study done, published in the IJO, where they had given Botox in the second month itself. They found resolution of symptoms in the patients who were given botulinum toxin. So this is our case where the young boy had right traumatic sixth nerve palsy after giving a Botox. This is his post-op picture, the down one. And this is an young male who had left sixth nerve palsy. He was given, he had undergone a Botox as well as a modified Nishada's procedure. Post-operative is the down picture. So whenever you have a sixth nerve palsy, always think whether it is isolated or non-isolated. Rule out always a trauma or malignancy. When it is age is less than 50 years, it is always neuroimaging is needed. When the age is more than 50 years, do the routine blood investigations, observe for 3 months, still no improvement in 3 months, revise, go again with the neuroimaging. Thank you.
I think it's a very vast topic and you have covered very well. One thing I would like to say, in children, we should also keep the possibility of amblyopia, because we should let them adopt an abnormal head posture if they are able to have fusion. And neuroimaging, of course, in ischemic age group, one may differ for some time, maybe up to 3 months in our setting. And otherwise, of course, in West, they like to do in all the cases.
She was given patching, the first child was given patching for 2 months.
Yeah.
After the 3rd month only, she was reviewed to the...
So I think that is very important to keep in mind, because they may go in for amblyopia. And also look for papilledema, because sometimes you may have papilledema. It may not be, it may be non-isolated, but it may look like isolated. So that aspect has to be seen. And if it is bilateral, then we have to be all the more careful, and that requires neuroimaging immediately. Anything?
Visual fields, I would say, I mean, in all cases of paralytic strabismus, one should not miss, always do a confrontation fields in your clinic itself. And whenever you have a little doubt, get the proper fields, because that may, even when you are waiting for imaging, it's better to do the fields. They may tell you something.
Any other comment? Yeah.
One more point, in case we are not imaging, we should call the patients every week to look for progression. So a very close follow-up is indicated in case we are not imaging.
Yeah.
If it is not improving, I think that again can be quite controversial, because some things with tumor also can improve temporarily. All that is possible. So it becomes a very difficult thing. But I think 3 months, if there is no improvement, one needs to
and in
definitely
this
go
3
in for
months, we
neuroimaging.
should call the patient very frequently.
And make sure that it's isolated. Corneal sensation is one of the tests that you should be doing in all patients, because you might be having orbital or cavernous sinus lesion with 6 nerve and only corneal sensation. Mahesh?
And just a bit out of the way, that in this situation we all have to remember Dr. Neil Miller says his 6th nerve is called the tumor nerve. Tumor nerve, and so it's always better to keep looking out for any additional signs and symptoms in 6th nerve.
Yeah, and Parkinson's syndrome with 6th nerve with Horner's in the cavernous sinus, I think that's also important finding. Once in a while you may get.
Yes.
What is your take on recurrent painful 6 nerves? What's your workup and management for that?
You have a recurrent painful one
Without a lesion.
Without a lesion, think of ischemia only as the major cause, and do a very elaborate vasculitic workup.
Because ophthalmoplegic migraine do present something like that.
But
and
after doing a vasculitic workup, you rule out all the systemic associations, then you can consider ophthalmoplegic migraine as a diagnosis.
Maybe
People should be consulted. Something, Peter's bone problems could be affecting that area with pain, 6th nerve and 6th nerve together. So I think ENT is
Even
also important.
I forgot, I had one case of Petrus apexatis which presented with a painful 6th nerve.
Yes.
So, but actually the MRI will give you the clue. But as you said, when MRI doesn't give you a clue, your vasculitic workup, the next...
because we do come across such young patients who are coming with painful 6th nerve, isolated, and the moment you come down on steroids, they will come back to you with the recurrence of the either one of the eyes. So have you escalated, Dr. Rohit and RP Center team? I would like to know,
Beyond steroids, have you escalated the treatment any time?
No, not really. No, I would not.
One more thing you can think is an low-grade CCF fistula, which you are missing maybe on the routine imaging, you can think.
And nowadays, of course, COVID also has to be kept in mind. We are getting cases of sixth nerve
And also
involved.
you have to have the pandemic associated also involvement.
That
go
also
with
is
the
true.
pandemic.
Thank you.
Thank you. Thank you very much. Next we have Dr. Jyoti Matalia from Narayan Mitralaya, and she's going to talk about ocular myasthenia gravis.
Good morning all. I'd like to thank Dr. Rashmin for this opportunity. I'm going to be talking on ocular myasthenia gravis, diagnosis and management, and I'll take you through the pathophysiology, the diagnostic tests, the management. So let's begin. We all are aware that myasthenia gravis is an autoimmune condition which affects the neuromuscular junction. It primarily affects the orbicularis oculi, the levator, and the extraocular muscles in both the eyes. The pathophysiology, coming to that, as you say, we know that at the neuromuscular junction, the acetylcholine that is released binds to the receptors. But in myasthenia, you have basically receptor antibodies which destroy these receptors, resulting in accumulation of acetylcholine and no generation of the AP at that junction, and hence the myasthenia develops. So what are the other important aspects? We have to know that these two proteins, the MuSK and the LRP4, are important in the construction of the receptors, and these are absent in cases of myasthenia. So let's look at how do you really detect these. So it's basically a clinical diagnosis, very, very important. Clinically, you need to find them out, and I'll take you through these 5 other aspects. So coming to it, clinical features, classically variability, very, very important. Ask in the diurnal how much it does make a difference throughout the day. Usually they'll tell you in the morning the patient is much better and worsens. It's associated with ptosis, which could be asymmetrical, could be unilateral or bilateral. Diplopia, because if the extraocular muscles are involved, there'll be difference of squint in different positions of gaze, and so diplopia. The pupils are, however, very normal, and that is very, very important for us to differentiate between that and cranial nerve palsies. Classically, the fatigue test. These are the tests that you do in a clinic. When you make the patient look in sustained up gaze, you'll see that the ptosis worsens. That's one. And then classically, the Cogan's lid twitch test. In saccadic check from down gaze to up gaze, you'll know that the upper lid suddenly overshoots. And this is the classical test to tell you that this patient could be having myasthenia. Then coming to the pharmacological tests that we do. First, before that, eyes test, very important. Do it in your clinic. You need to put the eyes over your lid for 2 minutes. Ensure intermittently that you can release, but check that the ice is actually touching your lid or not. Many a times it just touches the brow and then you really don't get the test properly. Very, very simple and effective test. The other is a sleep test, which after 30 minutes can see a resolution of ptosis or even ocular motility. Many a times that you're dilating the patient, you can tell him to close his eyes and rest and check him immediately post 30 minutes. That's one thing which you can do. And the other important thing is especially a history. In the morning when the patient gets up or after an afternoon nap, ask him how is his eyes. Does he feel much better? And that's one way to detect the sleep test which they do at home. Then the other edrophonium test, but now not available. So neostigmine is a long-acting anticholinesterase which you can do, and after 30 minutes you see a resolution of ptosis and even an improvement in ocular motility. Remember, the sensitivity is more for generalized myasthenia and about 86% for ocular myasthenia gravis. Coming to the serology, commonest acetylcholine receptor antibodies, more specific, helps confirm the diagnosis if positive, but normal titers does not exclude the disease, and in ocular myasthenia only 50% is the positivity. The other is a MuSK antibodies, positive in about 40 to 50% of generalized cases, but only 5% of ocular myasthenia with negative acetylcholine receptor antibodies. Third is LRP4 antibodies, positive in about 20% of OMG cases, who are negative for the other two antibodies. But interestingly, 10% of OMG cases can be triple negative, that is negative for all these, that we have to keep in mind. Then coming to electrophysiology, we find that single fiber electromyography is very sensitive, about 85 to 100% for OMG and 91 to 100% for generalized cases. Repetitive nerve stimulation study showing a decremental response in about 33% of poor ocular myasthenia. Now coming to the other tests, yes, CT's test to detect the thymic hyperplasia and the thymomas. Thyroid function test because there could be a concurrent autoimmune thyroid disease associated. So now that we have got it, let's go to the management aspect of this. So So the principles are two ways. Either you increase the acetylcholine availability or you prevent the acetylcholine receptor binding with the antibodies. And how can you do? We can do it pharmacologically. So these are the three treatment options that you have. First is pyridostigmine or mestinon. It's a prototype drug which inhibits, causing prolongation of the action of acetylcholine at the neuromuscular junction. No effect on the natural history of the disease, and only 20 to 40% of ocular cases exhibit a good favorable response. Then comes corticosteroid, which is the second line of treatment, along with pyridostigmine. It is up to 80% good in OMG, exhibiting good response, and can be combined around with pyridostigmine. And there's an epitome study in which they have shown that by gradually increasing 5 milligram, they have found that there is a good response in those in which prednisolone was given against those who did not get. And they found about 15 milligram per kg was the best dose they got to get the best results. So let's look at this particular case. That we had a child who presented with bilateral ptosis, left eye more than right eye, with extraocular motility showing limitation of elevation and adduction in the right eye. Depression by -3 and abduction was full, like a third nerve partial in the right eye and left eye complete ophthalmoparesis. Pupils were normal. So you have something like this. Remember, when it doesn't fit into anything and an MRI was normal for this particular patient, you have to see for myasthenia. And what we did is we asked the father that the morning she gets up, send us a photograph. And when we looked at the photograph, she was perfectly normal, indicating that this was actually a myasthenia. So she underwent treatment with pyridostigmine, that is mestinon, and corticosteroids, and did pretty well. You can see after first week, right eye is completely resolved, left eye is still having limitations, but after 3 weeks, there was a complete resolution, and after about 6 weeks, she is absolutely normal. The other aspect is immunotherapeutic agents. These are reserved for patients when corticosteroid risk exceeds the benefit and reduce the risk of OMG to GMG and changes the natural course of the disease. They have shown that 12% of cases of ocular myasthenia on immunosuppressives develops generalized, as against 64% who are on immunosuppressants either due to the late referral or uncertain diagnosis. So these include basically azathioprine, which is good for even ocular cases. You have mycophenolate mofetil, which is effective in ocular cases. Then IVIG and plasmapheresis left for those which are refractive. And finally, rituximab is more so for generalized cases. So surgical options are basically reserved, like thymectomy is beneficial in patients during the early course of the disease with significant follicular hyperplasia of the thymus gland. In non-thymomatous OMG, complete remission has been achieved in 50% following thymectomy and improved symptoms in additional 20%. Thymectomy can be considered in those which are which acetylcholine receptor antibody seropositive cases who have become unresponsive to medical therapy. So what is the basic algorithm then for ocular myasthenia gravis? Yes. Clinical examination, as I said, it's a diagnosis of is a clinical diagnosis. Eyes and sleep test, fatigue test. Look for any generalized signs. Rule out alternative neurological pathology. If after that you still clinically suspect ocular myasthenia gravis, do your acetylcholine receptor antibodies, the MuSK antibodies, and the LRP4 antibodies. If it's seronegative, you can do electrodiagnostic testing as mentioned here. If consistent or if seropositive, then you know this is a diagnosis of OMG. But yes, if you find all this negative, you need to do an MRI, which is also important in all cases, to rule out the actual cause, consider empirical therapeutic trial, and repeat antibody testing in about 6 to 12 months, which if positive will confirm the diagnosis. Hence, to summarize, if you have myasthenia is always a clinical diagnosis. It's a great mimicker, so you have to look at any patient who has got ptosis and with any ptosis or diplopia and absolutely normal pupils. That's important. Give importance to the history of variability and fatigability again and again. Don't forget that. Don't get biased by diagnosis anywhere else, and always coordinate with your neurologist to rule out a generalized case of myasthenia. Thank you.
Thank you, Dr. Jyoti. Comments from panel's experts, Chair?
Let me say one thing. I think we are a tropical country, so it gets worse during summer months. So one thing we should keep in mind. Another thing is diabetic population also is more prone for myasthenia. So with thyroid, we should also look for diabetes mellitus, because that is also autoimmune at times. So these two conditions are important and very common in our setting.
Ambika?
What is the protocol you follow for a myasthenia patient if you plan for a cataract surgery?
Do you escalate the medications or do you get a clearance? This is a simple question which I wanted to rule
I
out.
would get a clearance from our neurologist before doing it.
Yeah, because many a times, I mean, 1 or 2 times we have seen a myasthenic crisis
Okay.
post-cataract surgery. So you have to be primed for that also. If at all you're going to plan for any surgical procedure to a myasthenia
Especially
patient.
with anesthetic agents.
Anesthetic agents.
So we usually,
Preferably.
and we have it under a MAC, that is like a monitored anesthetic care at the same time.
And can I check whether if it is a pediatric myasthenia? Because most of the times in the pubertal age, around 12 to 14, there'll be a physiological thymic hyperplasia.
Okay.
How do you differentiate that versus a thymus lesion? And would you advise for a thymectomy in such patients?
Okay,
When they are not advising?
when it comes to management of this, I usually
Yeah.
coordinate with our pediatric neurologist. So my advantage is being in a health city, I have a direct correlation. So when it comes to managing, we both would decide, I'd get her opinion before we decide anything additional has to be done. So in case of taking decisions about medications, it's primarily that I refer to her and then together we monitor. So I will take the ophthalmic part of it and she'll be handling the treatment
Any
part of it.
pediatricians are less happy about thymectomies at that young age, and they generally would recommend unless it's only if it's a refractory myasthenia. They do not recommend. They're not. I mean, obviously because we want the entire natural immunity to develop. So unless it's like really significantly large hypertrophied or it's refractory, they tend not to. Of course, you need to always consult them. You obviously would not be the person who's be deciding, but in our experience, I've seen that pediatricians have been less than encouraging. Yeah.
Only
And
challenge
thymectomy
is
may
that
not always
Yes,
help.
please,
That is
please.
another problem.
only challenge is that if it's a malignancy causing this, the biopsies could be given important things. Recently, we have seen one case with multiple lymph nodes, sublymphatic with a thymus enlargement, with ptosis. So ultimately, probably in some atypical cases, you require a biopsy to prove these cases.
Yeah.
There are-
Malignancies can cause myasthenia, like Eaton-Lambert syndrome. That is another group of conditions, though of course they are slightly different. They are pre-synaptic, but they can also cause, and that's again you need to investigate and keep that in mind that the person could be having any kind of malignancy or any other disease. So a lot of masquerades there.
Yes, Manju.
That's very important.
Yeah, and just with the myasthenic crisis, I would also tell the patients that certain drugs need to be avoided, like beta block. So we don't want to precipitate myasthenic crisis. Your neurologist may or may not convey that, but that's an additional thing that I would say.
Yeah, right.
And two of the important clinical signs that I would recommend is, one is look at orbicularized ocular tone. That's one of the important signs which tells you that this can be myasthenia. And one sign which Dr. Arjun Das keeps referring to, early sign of a generalized myasthenia is that you will be able to push the patient's scalp because the neck muscle would go, their power will go down, so you'll be able to push the patient back just with one finger. So these are two clinical signs which you should look at, somebody who you suspect myasthenia.
Yes, one point which I have found consistently positive in some patients is smoking aggravates myasthenia or precipitates. So I've seen that in many patients. If anyone has had that experience, and stopping smoking definitely helps in.
Yes, I agree.
Probably
Yeah.
heat is an important marker, I think. Maybe smoke has, it's hot, so maybe it's yeah.
Most of the neurological conditions smoking
Can
is
be.
worse.
Smoking makes it worse.
I just wanted to add that most of the
And
pediatric
thymectomy
myasthenias
may not
are-
always help. So I mean, the results are not always. They may not always relate to thymectomy. So that's a very controversial area, indications and all those things. So I think we should not get into that area.
Yes, Dr. Virender?
Yeah, most of the pediatric cases have a self-limited course. So they may not require prolonged dose of immunosuppression also. They do very well with the initial immunosuppression with steroid, followed by being on pyridostigmine for a fair amount of time. They don't have so much recurrences. As compared to adults and younger adults who will usually have much more recurrences, relapses will happen. So
Pediatric also has neonatal and congenital, all those issues. So it's a very vast area again. And most of these are ocular myasthenia, so they are going to be okay with time.
Thank you very much. Next, the last talk of the session is by Dr. Himalini Samant, the host of this, one of the hosts of the conference. She's joining us from Just Look Hospital and director at the AIOC Associates Mumbai. She has some interesting cases for us.
Thank you, Dr. Rashmin. He always saves the best for the last, and a lot of my speakers have done my job, made my job much easier. So let's have this interesting session. The objective of this presentation is to discuss a few interesting cases. The presentation is designed for the general ophthalmologist. The theme chosen for the cases is ptosis. One needs to remember that ptosis is a sign. You need to determine the underlying cause. So a lot of times we're faced in the OPD with a third nerve palsy, with myasthenia cases. The ones who present with ptosis, the movements are not like, they don't pinpoint to an exact cause. And you're always wondering whether do we neuroimage these patients? Should we do a myasthenia workup? What should we do next? So that hopefully this presentation will throw some light on that. So the first three cases that I'm going to show are that of a third nerve palsy with a few similarities and a few differences. So the first case, 70-year-old, sudden onset drooping of the lid. He was a known patient of hypertension on medication. The pupils were reacting to light, the left side complete ptosis, and the EOMs were all suggestive of a left-sided third nerve palsy. So this is a video showing the EOMs. Okay. So the adduction was definitely limited, the elevation was also not there, and the depression was also not there. Now looking at the Bell's phenomena, okay. So if you ask him to tightly close the eyes, you see that the left eye, Bell's, was absent. A good orbicularis action, that is what Rashmin already pointed out. So every patient I see with a third nerve palsy, I also check their orbicularis action. So here the orbicularis action was good. So how do I approach this patient? The patient definitely had a left-sided third nerve palsy, which was pupil sparing. There were two differentials that came to my mind. The first one is, could this be an ischemic case because the patient was already a hypertensive, he was in that age group? Is this a myasthenia, like Jyoti said, but the orbicularis, the action was good, and the Bell's was absent. So the plan was that I decided to observe for 2 weeks, and if there was no improvement, or if there was any worsening, then I was going to go ahead with the MRI brain with contrast. So promptly, since there was no improvement, we went ahead with the MRI, and the MRI revealed an inflammatory pseudotumor. So the management was to start the patient on oral steroids. He was started with 60 milligrams on a tapering dose, and the blood sugar was monitored in the meanwhile. The EOMs have very nicely recovered the adduction, elevation, as well as the depression. The second case is that of a 65-year-old who complained of a sudden onset drooping of the lid. She was again a hypertensive along with a diabetic. The ocular examination was normal, and the EOMs were suggestive of a left-sided third nerve palsy. Now in this patient, this is the video of the EOMs. Okay. It looked like a third nerve palsy. And when I went to check for the Bell's was present. And if you take a look at this video, just see the first few seconds of the video. She had a large exotropia, but she was able to fuse. The first few seconds, and here she's able to fuse. So how do I approach this case? The patient had query a third nerve palsy. She known patient of hypertension. What were my differentials? So my first differential in this case was myasthenia. I felt that the ptosis was a little variable. She was able to fuse. The second differential was, could this be an ischemic, but could the cause be supranuclear as the Bell's was present? But the adduction was limited, so how does that explain? Could this be something else? So the first thing that we did was a receptor antibody test, which was negative. The blood parameters were all normal. And since both the above were normal, we decided to do a MRI brain with a contrast, which was also normal. So what next? I concluded that probably the patient had an ischemic palsy and decided to observe. But like Dr. Sujata mentioned, that if you're observing the patient, you have to make sure that you follow up the patient closely. So I warned the patient that if there was any worsening, she had to come back to the OPD immediately. After 4 weeks, without any treatment, the ptosis has recovered. She was only started on aspirin 75 milligrams just as a prophylactic measure. The final diagnosis was probably she had an evolving partial third nerve palsy, which was ischemic and got better on its own. The third case is another third nerve palsy. Similar presentation, sudden onset drooping and double vision. She was a very old lady, 75-year-old. She was a hypertensive and diabetic, but she was irregular on her medication. There was no adduction, abduction was full. It was pupil sparing, elevation was limited. So this, again, was a pupil sparing third nerve palsy. She had clear vasculopathic risk factors. economically not so well to do, so initially decided to observe. But a week later, like that sixth sense said, let's just neuroimage. And on doing an MRI brain with a contrast, we found that she had a large tumor and was suspected to have a METS. So what were the differences and similarities? The similarities in all the three cases were that they presented with sudden onset drooping and limitation of EOMs, all suggestive of a third nerve palsy. All had risk factors like hypertension and diabetes, and yet the etiological diagnosis was different. So one school of thought believes that all isolated third nerve palsies definitely need to be neuroimaged, and more so in the case of third nerve palsies, which are definite medical emergencies. I generally wait before neuroimaging directly, especially if there are financial constraints, and proceed stepwise like I've demonstrated in these three cases. If you want to neuroimage, most of us are in a habit sometimes of getting a CT scan done. So CT scan should not be done in any cranial nerve palsy. The choice of investigation is MRI brain with a contrast, if necessary, an angio. Every third nerve palsy should be carefully assessed, and myasthenia should be kept in mind. Ischemic cases require no treatment, just observe, control the risk factors. Definitely no role of steroids. The next case is that of a 45-year-old, and she complained of the right eye being slightly small as compared to the left eye. And she also said that the right eye was a little down as compared to the left eye. She complained of a non-specific pain on the right side with on and off headache. Her ocular examination was essentially normal. Now, on fixing with the right eye, she definitely had a pseudotosis because the ptosis improved. And on three-stepping, we found that she actually had a left superior oblique palsy. The patient, before she came to me, was extensively investigated for this ptosis and the hypotropia with MRI and an MG test, thyroid workup, inflammatory workup, and all of that. All I did was ask the patient for old photographs, and when we saw the old photographs, you see that the tilt has always been there, and in the lower photograph, you see that the ptosis was also always been there. So the right-sided hypo with the pseudotosis was evident from long, and hence this was a long-standing problem. It was actually a left superior oblique palsy. It was congenital, and that's why the patient didn't have any diplopia. The take-home message here is, look at the old photographs. Her vision in the paretic eye was better, and therefore she decided to fix with the paretic eye, and the pain was non-specific. So this patient was then operated. She no longer complained of pain. The surgery was done in the right eye for inferior rectus recession, left eye inferior oblique myomectomy. The ptosis is much better. So having a bit of strabismus knowledge always helps in neuro-ophthalmology practice. This last case is that of a 35-year-old. She had complained of right eye drooping, observed since a few months, no complaints of diplopia. The ptosis seemed fatigable. The ocular examination was normal. She had limitation of elevation in abduction as well as in adduction. How do I approach this case? So basically, she had an acquired monocular elevation deficit with ptosis. Could this be myasthenia? Could this be supranuclear? Could this be a partial third nerve palsy? Before neuroimaging, a simple test, which Jyoti has already mentioned. So the ICE test. The ICE test is a very simple, inexpensive test and saved this patient from undergoing neuroimaging. Her diagnosis was myasthenia. The next case is that of a 52-year-old who presented similarly with limitation of elevation and adduction and abduction. So if you look at this picture, her elevation in adduction and abduction were limited, but the Bell's was present. So therefore, this rules out that so both the previous case and this case had again some differences and similarities. Both presented with ptosis with limitation of elevation. The difference was that this case had a normal Bell's, and therefore we were suspecting a supranuclear lesion, whereas the previous case was myasthenia. So this patient was planned a neuroimaging, and the reports are being awaited. The take-home message is always test for your Bell's in case of limitations of elevation and ptosis. This next case is again a ptosis mimicking a third nerve palsy here, with adduction limited in the right eye, depression limited, elevation limited. But a simple test like doing the fatigue test, the ptosis worsened, but on doing the ICE test, it improved. Pediatric myasthenia gravis is not uncommon, presented at 8 months, bilateral ptosis, improvement noticed in the ptosis after starting the mestinon, and remarkable improvement after adding the steroids. Pediatric myasthenia gravis, the only thing that you need to remember is don't forget the amblyopia. Last case. Bilateral ptosis, few days of onset, old gentleman. Ocular examination were normal, extraocular movements were full, so I was planning to neuroimage and work up for myasthenia. But, you know, while we were discussing, he casually mentioned that he had taken injection Botox bilaterally as he had a problem of frequent blinking. So the take-home message is that apart from blepharospasm and hemifacial spasm, the use of Botox is increasing for various cosmetic indications, and hence, ptosis induced by Botox should be kept in mind. To summarize, ptosis is a sign. Pupillary evaluation is very important. Ptosis with normal pupils, think of MG. Dilated pupils, think of third nerve. Constricted pupil, think of Horner's. Always check for your bells, corneal sensations. Rule out pseudotosis. Check for fatigability and the extraocular movements. Thank you.
Thank you, Dr. Himalini. I think it's a wonderful collection of cases that you have presented. But just a general comment, and specifically in your case, we need to mask the patient's identity. I think that is very important. So many of the, and one of the slides also shows the name. So please edit, because these will be put up on the site of AIOS also later on. So be careful. So we should mask the identity, and the name should never come.
Yes, sir.
So please take care of that.
I think the first case you showed that at orbital mass, if we had done fifth nerve function, maybe we could have found corneal hyposthesia, and maybe those things should have been probably, maybe some proptosis, which probably should have been, I mean, had we done it, might have got an idea that it is probably, we are dealing with the orbital pathology rather a third nerve.
Yes, sir.
Yeah. Interesting.
So I think that brings to the conclusion of this National Symposium. I would like to thank the chairperson.
If we have time, I think we may have a discussion on the ischemic optic neuropathy, or somebody would like to talk, because that is one topic which got left out because Dr. Jaspreet is not there. I think just a simple thing that we all need to keep in mind, that we should always get an ESR and CRP done immediately, and give steroids only if that is coming positive, because many a times we are unnecessarily giving oral steroids to many of these non-arthritic ischemic optic neuropathies, especially the diabetes. The study done from RP Center, I think Rohit published in Ophthalmology, clearly shows that steroids are not having any role in non-arthritic ischemic optic neuropathy. Any other comments if there are?
It is quite often a wrong diagnosis or misdiagnosis. That is also a problem. But still it gets misdiagnosed, something else. And
so if nothing else, then thank you all. Thanks, Rashmin, for this nice presentation.
Thank you so much. Yes, ma'am.
And it's not necessary in all cases of the giant cell arthritis, the systemic sign and symptom should be there and the inflammatory markers should be raised. If we get a pallid disc edema in elderly patient, arthritic ischemic optic neuropathy should be diagnosis, because occult GCA or silent GCA is a well-known entity. Dr. Harry himself had this thing. So we had 3 cases, So one should think systemic symptoms are not necessary, or the inflammatory markers to be raised to make a diagnosis of GCA.
I think
before
we leave, just be, all of us, the panelists and all, let's have a group photo of the neuroophthalmology.
But do we see it frequently? Giant cell arthritis?
We underdiagnose it because we think it is not existing. But we should.
Probably.